So welcome to HiNZ 2017, and this afternoon I'm talking to Roy Smythe from Philips, and Roy gave a really interesting talk yesterday on breaking the barriers to seamless care. So Roy, talk to us about the three waves.
Sure. So I talked about the three big paradigm shifts in healthcare that are going to occur from the progressively more sophisticated use of data. And I think of them as waves because, they're going to move us from one place to another. The first wave is the effective collection of data in the clinical setting. It sounds somewhat mundane, but as it turns out, most healthcare providers around the world are just sort of in the early phases of collecting, accurate, useful data that can then be applied to other activities in healthcare other than just billing and coding. Like changing the way care is delivered. And a lot of that has to do with the adoption of electronic health records, which are a relatively new concept. Most, I would say, medically developed countries have adopted EHRs, but again, it's been for most of them in the last 5 to 10 years, and so they're still learning how to use them. The second wave is using the data that you collect from the clinical setting and from other places to give insights back to clinicians caring for patients. So the concept here is that most physicians, I was a physician, I was a cancer surgeon for a long time, and so when you have a patient sitting in front of you, you're operating with a knowledge base that's based on the other patients in your practice that you've seen like this patient and the medical manuscripts that you've read, so maybe there's a few thousand patients in your database. And the concept about leveraging data in this way, in the second wave, really effectively is that clinicians can know patients through the experiences of all other patients like them around the world, potentially. So, if you're collecting genomic data and activity data and diet data and healthcare intervention data, et cetera, on individuals, and then feeding that into a pool of data from which clinicians can reach into and derive insights, then they really know their patients in ways they don't know them now, and we've never known them. That's the second wave, and so that wave, a lot of people talk about that they're actively doing that, but we're really just scratching the surface there. The real prize is the third wave, and that's when we actually use that pooling of large amounts of data in a healthcare context and deliver insights directly back to individuals themselves, laypersons. You could imagine, I call it the perpetual global clinical trial. You wake up every morning and your Alexa device or your Amazon device in the room says good morning, and based on other people like you around the world, you should probably do this with your activity. I suggest you get more vitamin A in your diet over the next month. You should divide your blood pressure medicine into 3 doses rather than 2, and you should probably go back and see your physician a month earlier than originally planned, because the data that the system has suggests that a problem could be brewing. And so you can imagine the power of that. And then, of course, I think there's some societal benefits even beyond healthcare for that sort of platform.
One of the things that you focused on also, Roy, was the patient, knowing the patient.
Sure.
And you described what the traditional knowing the patient is versus what the patient wants. Can you elaborate that on a bit more?
Sure. So, well, I think when you think about what patients want, you think about things like they want the clinician that's caring for them to be competent. They want the clinician that's caring for them to care about them. They want the clinician that's caring for them to, understand their disease and try to attenuate it or even cure it or prevent it in best case scenarios. But to me, the most essential existential need of the patient is for us to know them. Because if you don't really know them, you can't do any of those other things very effectively. And again, it's this concept, do I really know you if I only know you? And the other patients in my practice like you, and again, the medical manuscripts and research papers that I read when I was in medical school or when I was training that have a few thousand other patients. When, if at some point in the future we're pooling data around the world and we've got 4 billion patients contributing their data into a single data bank, And there just happens to be 100 other thousand people in the world like you, similar genomics, age, gender, activity, diet. And these individuals have experienced things and have had either reacted to or not to medications and so forth. And then my ability as a clinician to know you through the experiences of all of the people like you is, dramatically higher.
So is this a way, through the use of that data in the waves of, I'll use it, to fast tracking that knowing of the patient as opposed to knowing them in a building up or in an evolving way? Is that what you're saying too, that you have to find a faster way to know the patient, and the data is helping or can help to do that?
Well, I think it's not just faster. I think in the current model of healthcare, we can't really know them in this way fast or slow. I mean, we're limited.
You don't know them at all.
Our data's limited. Our information on individuals like you is very limited, and this is knowing them in a medical sense. It's not the same as getting to know them as a person. But here's an interesting concept. I actually believe that when we move down the pathway over the next however many decades, all three waves will take. When we're leveraging data and artificial intelligence to take some things off of physicians' plates, mundane activities, removing the need for them to read a screening chest X-ray anymore. They only need to look at the complex, images. I actually think that this interpersonal part of healthcare will increase. I think that healthcare will become more humane. Sounds a little counterintuitive that technology will make healthcare more humane in the future, but I firmly believe that. We're in a messy transition period right now. Our technologies now actually make healthcare less humane, but it's a phase that will come and go. And in the future, I think we'll not only know your patients better from the standpoint of their biomedicine, but you'll know that you'll have the opportunity because of technology taking some of the things off your plate that we now have to do, to know them as people better too, and that's often important, as you know.
So it reminds me, one of the other speakers used the term that said machine learning and AI would help in allowing the clinicians to work more at the top of their license.
Yeah.
In other words, taking away some of that responsibility to either create the data administratively or absorb the data, but to focus more on their true professional. And is that sort of thing? It sounds like that there's
it's definitely a part of it. So here's a really simple example. In North America, the average primary care visit is 13 minutes long. And then of that 13 minutes, 39% of that time is spent doing non-clinical activity. It's typing data into the EHR template or documenting in other ways. So that means the average visit gets down to 8 minutes now. What if you had 30 minutes and had nothing to do but sit across and look in the patient's eyes and ask some questions? That's really difficult now for clinicians to do. We've created technologies that have improved healthcare, there's no doubt. EHRs, and despite the dissatisfaction with the documentation process that physicians have with the current EHR, this time will pass. And it's already wrought some benefits for sure, but nothing like what's going to happen in the future.
And does the training, either undergraduate or postgraduate training, let's say in the medical schools or the nursing schools, is that training in those curriculums, is that keeping up with the evolution of how data, the technology?
I don't think anything's keeping up with it. And this is, if you study the history of the development of technology, this is not unusual. So, oftentimes technology sort of screams ahead of our abilities to understand it and use it. The amazing thing is we always catch up. We always catch up. So no, technology's out in front of us right now, especially in healthcare. We have a surfeit of devices and software and other things that we could be applying to the clinical condition right now that we can't yet because the regulatory environment hasn't caught up. The data security environment hasn't caught up. people are still trying to wrap their heads around how to incorporate it into the existing model. So, but it'll happen. Who would have thought a human being could drive a car 200, 300 years ago, right? Who would have thought that? I mean, were we engineered to do these things? As it turns out, I call this the fate of man and machine. So the fate of man and machine is that we haven't invented a technology yet that we can't actually master to make us more competent at doing things. We're just, we're a little behind the curve in healthcare.
So how do you go about bringing your let's say former colleagues, because you were an oncologist, were you? Or
oncology surgeon.
Oncology
yes.
surgeon.
Yeah.
So how do you bring them along on that journey in terms of changing a behavior change and how they actually deal with getting to know the patients? How does that work when it?
Well, I think in most parts of the world, to be a physician, you have to be an adult. And I'm a firm believer that you don't change an adult's behavior. You have to convince them that there's a reason for them to change their own behavior. And so, and you can't, physicians don't like mandates, and this is a global phenomenon, just not just in North America.
Yes.
They tend to be, type A people that are relatively bright and hardworking and relatively focused. And so, you have to give them proof points, and you have to, in addition to proof points, something I think we've sort of forgotten about is that you have to appeal to their higher order values. Telling a physician that you need to be more productive because I need you to generate more productivity numbers and generate more revenue for the clinic or the health system or the health service, or make better use of the health services resources, there's not really any higher order values in that. But to tell a clinician that, hey, listen, here's a tool that if you use it and you master it, your patients will have better outcomes. It sounds hokey, but you'd be surprised how infrequently we appeal to these people's higher order values. And in addition to being all those other things, most of them got into healthcare because they felt like there was a mission for them. And so, for me, it's convincing them to change their own minds, giving them proof points, and then appealing to their higher order values. And I've only been on the industry side for 4 years, but if I'm talking to a physician about a new technology or a new device or a new piece of software, and I can't understand myself how it's going to improve clinical care, well, then I'm not talking to the clinician about it. I'm not, because my background is as a clinician myself, and the tools that we use should be designed to do a very discrete number of things. They should make healthcare more effective, efficient, and equitable. The last one's difficult. They should relieve suffering and maintain meaningful life. And if I can't convince a clinician that I'm going to be able to give them a better tool to do those things, well, then I'm not trying to convince them.
That's great. Thank you so much, Roy. It really is appreciated.
Thanks for
and
having me.
The talk was great, and thanks also to Philips for their sponsorship.
That's been a great meeting. We've really enjoyed being here. Thank you.
Just sorry you're only here for 2.5 days. Thank you.
You bet.
Thank you.